Okay, why don't we get started? Uh, as most of you know, we've got two parts to the meeting. The first is Commissioner Monica Bharel from the state of Massachusetts, the Department of Public Health, will be speaking, and then we have a little bit of business related to the hub that we will do after she's done and after we've finished up with questions. So I'll start maybe with a brief introduction. On these calls and a lot of other forums, we often talk about the power of data sharing and how difficult it can sometimes be to kind of navigate the barriers to stand in the way. I thought this talk would be interesting because several years ago, the commissioner and the governor and the state legislature did what I think we would recognize as a truly remarkable thing. I'm going to oversimplify it a bit, but in essence, they passed a law that said for opioids abuse, data sharing will be the default as opposed to the exception, which really opened some interesting doors. A few years ago, when I heard the commissioner speak at a workshop, I found myself at a table with someone representing the local county jail, literally, the statewide community health system, an insurance carrier, and a data scientist, kind of all mixed together, which is a really interesting crew of people to apply to a really difficult problem. So a couple of years have passed since then, and I'm as interested as all the rest of you to hear how things have gone since then. So I will turn it over now to the commissioner. Thank you very much for coming to speak.
Hello, good afternoon. Can you hear me okay?
Yes.
Yes.
Wonderful. So thanks so much for the introduction, and thank you for your interest in this topic. When you talk about the power of data and what we can do with it and how we can use data to inform policy and programming, and I can't think of a better example that I've been involved in. So I really appreciate the opportunity to share our work here. What I'll do is I'll give you two examples, the second one being the one that you mentioned around the legal changes we made of how we use data to address our current opioid epidemic in Massachusetts. As you alluded to, the opioid epidemic is a complex medical illness, and there are multiple different ways it could be approached in terms of what way to make an impact. When Governor Baker was elected in 2015 and our administration began, he declared the opioid epidemic his #1 health priority. We began then in his administration developing an action plan of how to address the current opioid epidemic. And one of the key components of addressing this complex medical illness for us, and a real cornerstone, has been to use our existing data that we already collect to turn that data into actionable information and wisdom so that we are targeting the appropriate places to put our interventions and limited resources. So with that, a minute ago I could change my slides, so let me try this way, perfect. Looking at, so the first thing I'd like to show you is our quarterly reports, and then I'll talk about the Chapter 55 legislative changes that we made. So in Massachusetts, we, prior to this current opioid epidemic, would put out opioid death reports with about a 2 to 3 year lag. And this was due to waiting for all of the medical examiner's work and the other clarifications to be made and a death being fully determined to be from opioids. With the current opioid epidemic, which had changing characteristics every day, we knew that we had to act faster. And therefore, our team here at the department developed a predictive model, which allowed us then to release data related to deaths with only a 3-month lag. And this really allowed us to have more accurate information that, again, was more actionable. So here's an example of the data that we present in our quarterly reports. And what you can see here is the annualized data up to 2017. And you'll see that the red bars at the end on 2016 and 2017 are the data that we achieved through that predictive model that I spoke to you about. And what this clearly shows is that from about 2013, we really have this unbearable spike in deaths related to the opioid epidemic. What this also shows us is that we have seen, really, if you go back to 2000, a really remarkable, almost 500% increase over this 16-month period. And we wanted to investigate further this spike from 2013 to 2016 to understand it better. And of note, I'll come back to this at the end, but you do see a flattening or a decrease, if you will, in some of those deaths between 2016 and 2017. And I believe we're one of only a few states who have seen that. But let me delve further with you into this opioid overdose death report. This shows, this is looking at that same information, looking at the death rate, and gives you a clear picture of, as with many epidemics, we see this rise, and hopefully, we're really hopeful that we're beginning to see a leveling off. What you'll see here is that we began to say, we understand that people are dying, we understand that more individuals are dying. We really want to dig deeper into understanding these deaths so that we can prevent them. So what this shows here is a really collaborative effort that we had across different secretariats, so working across both health, where the Department of Public Health sits, and the Office of Public Safety, where the Office of the Chief Medical Examiner sits, to be able to really analyze each death, either confirmed or predicted from opiates, to look at the components of that. So what you see here in front of you is what was really important information for us to find out, which is the unfortunate presence of fentanyl in individuals who have overdose deaths. The reason it's important to understand that fentanyl is present is that when individuals use illicit fentanyl, that fentanyl is 50 or 100 times more potent than heroin or other opiates, and therefore has a much higher chance of causing death. So this begins to unpack for us those rising numbers of deaths that we're seeing. And you can see this data goes out to the second quarter of 2018. And you can actually see the crossover. The red line is heroin and the blue line is fentanyl. You can see that crossover point where we begin to see that there's more deaths associated with fentanyl. The percentage is higher, up to 90% now in Massachusetts, than heroin. Much of this data also helps us understand what we're hearing from the field and from frontline individuals and providers, saying that, don't forget about benzodiazepines. That's the green line here. That's still an issue. We're still seeing a lot of cocaine. That's the purple line here. And this helps us, again, begin to see what individuals are dying from. Digging further into the opioid death data, we were able to see that the majority of individuals, 73%, were male and about 27% female. Looking at it another level, we often talk about individuals and how the opioid overdose is taking the life of our young people in premature death. And what you can see here is when we looked at the deaths by all ages, that's the top bar you're looking at, you'll see that about 78% of the deaths are in individuals age 65 and over, and that's what we would expect with normal aging patterns. However, unfortunately, when we look at opioids, we see that the majority of deaths are in individuals in the age group 25 to 44. So taking individuals at a younger age, and again, as we think about this from a programming point of view, and we're targeting individuals for interventions, understanding that this is an age group 25 to 44, and then before 25, that we really need to target with our interventions and prevention messaging. In our last couple of reports, we also began for the first time to look at those toxicology and death reports by race and ethnicity. And I mentioned to you earlier that we were thankful to begin to see a decrease in the number of deaths. And you can see here, looking at it this time by race, that in the all category, there's an 8.4% decrease. In the white non-Hispanic, a 10% decrease. And in the Hispanic, a decrease as well. But unfortunately, we see that in our Black non-Hispanic communities, it's the only group where we're still seeing rising numbers. And in fact, again, when for the first time we broke that down by gender, we see that you'll see in the blue circled area that the high rates are really related to Black non-Hispanic males. And information like this, if we had only looked at that highest level of data and not stratified in this way, we wouldn't be able to see that this is a group among us that we have to target interventions and make sure that all of our policies that are bringing down the death rate are also getting to all populations. I'll move now to talk about the Chapter 55 report that you heard a little bit about in the introduction. So the quarterly reports have really helped us provide timely information. Many times a complaint of information that comes from big data or from state-based data is the timeliness. Another complaint is that we look at data in their silos, if you will. So what we did was working through the governor's administration and with our legislative partners, it really did take a law to be changed in order for us to look at this data in this way. So what we did is the law required us to answer 7 specific questions that were based on what could be actionable, and that we would have specific databases that we brought together and that would overcome legal barriers for this. If you look at this slide here, you'll see what some of the data mapping entails. There's a code to say where the data sources were, but I want to draw your attention for a minute to the gray buckets, because those are buckets of data that sit within the Department of Public Health. But the way we sometimes compartmentalize big data is interesting, because if you look, for example, at the prescription monitoring program data and the BSAS data, which is our addictions data, and you look at the death records, these all fit within the Department of Public Health. But because of the way the legal structures were set up, even as the Commissioner of Health, I couldn't bring together those different data sets to try and answer some of these very challenging questions about how to care for individuals dying from the opioid epidemic. So what the law did is it allowed us across these different buckets within the Department of Public Health, across the Executive Office of Health and Human Services, and throughout the governor's administration to look at different pieces of information. And this really opened up our ability to answer some of the really challenging questions about the opioid epidemic. And really, for the first time, we were doing things like taking birth and death data with addiction data and medical data and prisons and jail data and so forth, and putting it together to get a true picture of what was happening in this opioid epidemic and what are the actionable steps we can take. So I'm going to walk you through just a brief overview of some of our findings. Before I do that, I always put this slide in when I talk about this because it's a really important piece. As we were looking at our state response to this problem, the data analytics that you see bringing all of this data together, there was no additional funding that could be put to this because we had to put the funding that was coming in to the services that the individuals needed suffering from the disease. So we undertook for the first time a very innovative private-public partnerships with the members you see on this slide, and there were others as well. This is a representative sample, came together in private-public partnerships to offer us voluntary resources such as data analysts, epidemiologists, data scientists, AI expertise, et cetera, to help us complete this project. So here are some of the findings for you to see. So first of all, this looks at the prevalence of opioid use disorder, and we see in Massachusetts in 2015, about 4.4% of the population suffers from opioid use disorder. Now, this is actually just published in the American Journal of Public Health at the end of last year. And this may seem like, well, how would this help with the care that we're providing? You know, this is really critical because if we look at other medical diseases, when I was a general internal medicine physician, and when I was in my clinic, if I was trying to take care of my patients with diabetes, it'd be really important to know how many of them there were so I can understand what resources are needed and what I need to do for them. By bringing together all these different data bases, we were able to get a better estimate of the true prevalence and how it's been rising. And it actually, this estimate is more than double what was previously thought. I should note that the data I'm showing you now is all from 2011 to 2015. The data linkages were made over that time period, and we're working now to go beyond from 2016 and beyond. This next slide that you're looking at is a survival curve. We use this a lot in medicine, but we hadn't had something like this before to look at our opioid epidemic. What we did was look at individuals who died from an opioid overdose and then went back to look at their first use of a prescription opioid. And this slide has really helped me when I speak to our legislative partners and others about programming and policy changes, because you see that unfortunately, in order for us to act and assist individuals who are suffering from opioid use disorder, we have to act fast, because from the time of that initial prescription to death is unfortunately a very quick, only 36 months. This really becomes a call to action for all of us in our programming and policy work to work quickly. Next, I want to show you some information that I found very helpful in speaking to my clinical colleagues. You'll see on the left side of your screen, individuals who are engaged in OAT, and that's opiate agonist treatment. So that's medications that work to assist individuals who are suffering from opioid use disorder, methadone or buprenorphine. On the right-hand side, the tan bar, you'll see those who are not engaged in opioid agonist therapy. And what we saw is when individuals presented with an overdose, but they didn't die, a non-fatal overdose, that's a really important time to engage them in treatment. And what we found that if the individual was engaged in treatment versus not engaged, their risk of death went down almost 50%. And we also found that unfortunately, in this database, only about 5% of the individuals who needed that treatment were getting it. And there is decades worth of peer-reviewed journals on methadone. There's dozens of articles on the efficacy of buprenorphine. But something interesting happens when you show individuals localized data. So this is a localized Massachusetts data. This is what's happening here in Massachusetts. That becomes a really powerful driving force. When I talk to my clinical colleagues, and they say, what can we do to address the opioid epidemic? I say, well, look here. People are not getting the medication they need. And in fact, if we really want to decrease the number of these rapidly rising deaths, treating people with these medications will decrease that risk by 50%, as good as medications we use for diabetes, high blood pressure, better than some chemotherapies we have available. So really, this has been really powerful to help us spread the use of medications throughout our system in Massachusetts. We then wanted to really take a look at some of the highest risk groups so that when we look at our resources, we can target them to address who's at highest risk. And I'll show you a couple of those now. What you'll see here is these are individuals with a history of incarceration. So this is both history of jail and prison. And what you can see here that unfortunately the opioid death rate is 120 times higher if someone has any history of incarceration. And furthermore, we found that some of the highest risk is right when they're released from jail or prison. And this fact alone and the data pieces that are behind it have opened the doors for us to speak with our criminal justice colleagues in ways we have never been able to do before. And understanding this risk for individuals as they leave incarceration has been a real powerful motivator for our colleagues in criminal justice. And in fact, in our opioid law that the governor just signed last August, there is now pilots where several of our houses of correction are working directly with the department to figure out ways to get treatment for individuals while they are still incarcerated. This next slide looks at individuals with any experience of homelessness. Of note, I will say that from a data point of view, it was very challenging at the state data level to be able to identify someone who had a period of homelessness, much less housing instability. So we developed our own model in order to predict who in the database had an experience with homelessness and saw that the risk was 30 times higher for opiate deaths. So again, targeting not only getting individuals the treatment they need for opioid use disorder, but making sure they have a stable place to stay during their recovery and after. This looked at the intersection of serious mental illness with fatal opioid overdoses, and we see individuals with serious mental illness have a higher risk of fatal opioid overdose. And that includes SMI, which is, includes illnesses such as psychosis and schizophrenia. And what this data point did for us is it really allowed us to begin working in innovative ways with our colleagues in mental health to say, as we design programming to care for individuals with opioid use disorder, we must be able to care for mental illness as well. And the final high-risk group I'll show you is pregnant and postpartum women. And what we found here is that, interestingly, a year before delivery, if you look at that, that's the overdose rate event, and it goes down during pregnancy, which some people may predict. However, what surprised some of us was that after delivery, the highest risk for the mother to overdose was in 6 months to 12 months after delivery. And what this helped us understand, making it actionable data, is that programming and support that often lasts for a few weeks or a couple of months after delivery really needs to be more prolonged to help support the mother and her child in this very risky time period. Some of the data that I'm describing to you, we then visualized so that individuals in communities, whether it's individual community members, friends and families of those with opioid use disorder, or individuals who are working on the opiate epidemic at the community level, could look at their data. And I urge you, when you have a chance, just to take a look at the link below. There's some basic videos and description of what opiates are and what the epidemic is, but it also goes through, and you can town by town look at what drugs, the drugs that are used in those towns, and some places you can see, for example, where their first most popular drug used to be alcohol, and now it's opiates. So it's meant to give community members more information in a very tangible, interactive way. And again, for the first time, because we know solutions to the opioid epidemic start in the communities, and the communities looking at what they need, we wanted to empower individuals to have this information. And I should tell you that the Chapter 55 was initially a 1-year legislative mandate to answer 7 questions. However, after that, we were allowed to do another year. And finally, in the 3rd year, we were given the legislative capacity to build a public health data warehouse where we can now continue to answer questions, not just related to the opioid epidemic, but whatever the next public health crisis or epidemic is. So it allows us to bring this data together continually to continue to answer valuable health and public health questions. I want to just end my formal part of talking with a couple of things about how we went about in our opioid working group, and you can see how it relates to some of the data points I gave you. As I mentioned, the governor had a multi-sector group come together, including myself and my boss, Secretary Sutters, in an opioid working group, and we came up with an action plan with dozens of actionable steps on how we would address the opioid epidemic. The areas included looking at prevention, both in the area of safe prescribing and prevention of opioid use among youth and individuals, and then interventions and treatment and recovery. So in the area of safe prescribing, legally in Massachusetts was one of the first states to put a 7-day limit on first-time prescriptions, a requirement to check that prescription monitoring tool that I mentioned to you earlier, and then prescriber education. And in prescriber education, we were the first state to bring together all of our prescriber schools, along with our associations and state government, to come together and say, we understand that we need to do more teaching around how to balance pain management with the potential for opioid misuse. So we came together, this is published in Academic Medicine if you want to see the details, and our medical schools, dental schools, NPs, PAs, community health centers, and social workers have now adopted this, actually, as well as our physician, physical therapists, so that there's more education in this area. This is a sample so you can see what our parent campaign looks like. We've launched it to multiple different communities, and it's really about talking to children about the potential for misuse of prescription pain meds. Here I showed you some of that race, ethnicity breakdown in the beginning of my talk, and here's just a sample of our same ad on Stop Addiction Before It Starts in Spanish. We've done a lot of work in the area of Naloxone, or Narcan, the reversal drug for an acute opiate overdose. I didn't show you that data, but we have a lot of data showing us that when that when an individual gets naloxone, whether it's from a first responder, a bystander, which is family or friends, or through a pharmacy or other program, then it really allows them a chance to turn a potential fatal overdose into a non-fatal overdose where they could then get treatment and recovery. And in the area of treatment, we've increased, we're up to many more beds, so that there are more treatment beds, and expanded our availability of medications, which I mentioned to you earlier, as well as targeted, I give you some examples, some of these highest risk groups that we're finding. We also revamped our helpline where individuals can call in and now do a live chat with someone. This line is also completely now available in Spanish as well. And finally, I spoke about stable housing, and we have over 2,000 now stable home beds that are voluntarily certified, and working with recovery support and recovery coaches to assist individuals in the recovery process beyond treatment. I'll go back to this to say all of those efforts that I sketched out for you, and I gave you just a sketch, are part of the efforts both here at the Department of Public Health and throughout our state government, but really also throughout our communities, where we're beginning to see a slight amount of relief with a slight decline in these number of deaths. And as we've been talking so much about numbers, before I open up for questions, I do want to recognize that having done this work clinically for a long time, we're talking about almost 2,000 individuals, over 2,000 individuals losing their lives prematurely. And behind each one of those individuals is a family member, a community, and really devastating impacts of the disease. So using the data in this way it's a call to action for all of us to take part in solutions and to make sure all the questions that we are asking and answering really can impact these individuals. And the last thing from a data point of view I'll show you is I mentioned our prescription monitoring program is now required. And you can see from here, the green line is the number of searches by prescribers and pharmacists. And you can see how that has that bump right when we put a new system in place, and then it became a legal requirement to use the system. So you can see that bump up and then steady usage. And importantly, you could see that the blue line is the total number of opiates, the Schedule II opiates that are prescribed. So you can see that going down to about a 37% decrease since the beginning of 2015. So 37% less opiates out in the community. And along with that, we know that the rate of individuals of concern, so potentially individuals who may be misusing those, has also gone down along with that rate. So we see slowly, progress in this area. I gave you a lot of data and facts. If you're interested in some of the more information on our helpline, you can see that's up there. The link at the bottom is to that Stop Addiction campaign if you'd like to see that. The link in the middle, it's really where I would send you if you'd like to look more in depth. I gave you snapshots of some of our findings. If you go there, you'll see much more detail about how we put the Chapter 55 reports together and all of the data details behind what I briefly presented to you today. I really thank you for allowing me to be here with you. You'll see here ways to connect with us at the Mass Department of Public Health and ways that places where we post updated information, including our quarterly reports. I would like to open it now if there's any comments or questions that I could be helpful with.
Hi, this is Renee Bastone. Thank you. I'm the Executive Director of the Northeast Big Data Innovation Hub. Thank you very much for the presentation. That is amazing work. And I'm very interested in the possibility of following up with you. I'd love to learn a little bit more about whether other states are starting to look at Massachusetts, particularly in the Northeast, to try to model what you have done and create similar programs and see if there are ways that we may be able to help in trying to replicate your fantastic work.
Thank you, and I appreciate you listening in. You can feel free to email me. It's monica.bharel, my name, at state.ma.us. And I will say that, I can't speak in detail about other states, but I do know in Massachusetts, I know on these calls you often speak about barriers. And one of the barriers was around really figuring out a way to bring this data together in a way that complies with our legal requirements. We all take the security of our data, as we should, extremely seriously. And one of the innovative things about the way we brought this data together is that we were bringing different silos of data together, but only temporarily linking it in order to answer specific questions behind a privacy shield, and then delinking it or decoupling the data. That was a really important part for us, and it really helped our legal teams across these different data silos feel more comfortable. And I should add, though, for our researchers and our partners who you saw the list of, it did add an increased burden, but we wanted to be so careful when they physically had to come to the Department of Public Health to do any of the analytics. So we weren't sharing data in any way. And all of those pieces really helped us push this forward.
Oh, that's very useful to know. So you developed essentially a secure enclave at Public Health Department where everybody had to work. Yeah.
Yes.
Fantastic.
This
Well,
is, sorry.
No, I was just going to say thank you, and I'll definitely follow up.
This is Jim Wogenbush, University of Minnesota, Minnesota Supercomputing Institute. Thank you so much for your talk. That was excellent. You spoke to one of my questions already, and that was sort of what sort of challenges that you had to address specifically around the data privacy issue. I wondered also if you now might be able to use this framework that you've developed for other challenges, not just the opioid crisis, but possibly if you're looking at using some of the infrastructure that you've created, some of the culture that you've created around this to address other challenges. A lot of us here on this call are what we call cyber infrastructure engineers, and we love to be able to recycle or to point to cases that we might be able to use to address other challenges.
It's a great point, and one of the reasons I'm happy to share this is I do think it can be translated for other issues as well. So as I mentioned, when we first asked for the Chapter 55, we purposely, because it was new territory for Massachusetts to be entering, and it was a 1 year so that we could answer the 7 questions. And then we again asked for another year to continue to ask the questions, and those were specific around opioids. What we have now accomplished is the capacity without an end date to do a public health data warehouse. And the way that that legislature is written, and I'm happy to share it through the organizers, anyone who's interested in having it, the way that legislation is written is that the questions that are asked and the priorities are based on the priorities that the Commissioner of Public Health sets. So we're looking at opioids right now, and we're now specifically looking at opioids related to maternal child health, but we will then also look at other issues related to maternal child health, and then whatever issues come next. I will tell you that I mentioned that the data was linked from 2011 to 2015, and now we're going 2016 to 2018. So, continuous capacity to link is something that can be a barrier as well, because at this point, when we started using this, it wasn't old, but now it's becoming old data, and all of the work that our administration has done has been 2015 on, so we're eager to look at some of these things in light of all of the new programs that we've put in place.
Excellent, thanks very much.
I have one more question. I didn't want to monopolize. I was pausing. It sounded like you mentioned a lot of different cities are available in the visualization view. This is Renee Bastone again.
Yes, yes.
How far did the work extend beyond urban areas into suburban and rural areas?
That's a good question. So if you go to that link and toggle over it, you can see all 351 towns and cities in Massachusetts. And if you go to our the link, I'll put it back up, that I sent, the mass.gov/opioid response, you can get our quarterly reports there, and we report the deaths by every single town and city. We just suppress if it's small numbers, but so even the towns of 150 individuals, it's all in there.
Oh, that's great. And maybe you don't know this off the top of your head, so it could be an unfair question, but did you find any substantial differences in the death rate on a per capita basis between rural areas and urban areas?
Yeah, I don't have that off the top of my head. We have done some looking at when you look at the opioid use prevalence rates, and there's some nuanced differences that I'll point you to our American Journal of Public Health article that just came out at the end of December that some of our researchers used some of this data for. But we do have, if you go to our site, you'll see this kind of a heat map of the state of Massachusetts, and that might be helpful to look at as well.
Great, thank you.
And I do have time for one more question if there are any other questions before I have to hop out to another meeting.
Well, this is John. I'll give it a try. You listed quite a few academic institutions being part of the initiative. Since this group represents academic institutions nationwide, I was wondering if you could just say a few words about how you think the academic and the research community was able to uniquely or especially helpfully contribute to the effort.
It's a great point. We could not have done this work without our colleagues in academics and research. The way that we approached this, because as I mentioned, we really wanted to develop these relationships. And I must say that our academic and research colleagues around the state of Massachusetts wanted to contribute to answering questions and helping with the opioid epidemic. Because of that alliance, and then really based on relationships and a notice of intent that we put out that these are the questions we wanted answered, we were able to bring in individuals to do this work. I will say, having been on the academic side of it, one thing that was different is, as you all know, many times we apply as an academic for a grant and we have specific questions in mind, and then we go to a big data set to answer them, right? And what we did here was we kind of flipped that relationship and said, as the state of Massachusetts Department of Public Health, we need to answer these 7 questions. Well, these are the 5 areas we need to focus in. Can you come and help us answer those questions? So it's really a changing of the relationship, but it really was a win-win because we were able to answer these really critical questions, continue to work with our colleagues, and many of them then were able to work in the space of big data in ways they didn't necessarily have access to before. And we have published collaboratively with the department and our colleagues in academics, several peer-reviewed papers on this, and there'll be more coming in that area.